Connie, you want to go next?
Sure. Hello, my name is Connie Sung, and I'm also a second year. Wow. Yes, oh my gosh. Thank you so much for that, Miss Abraham. I still remember biceps femoris from two-headed dragon leg muscles.
You're welcome. I'm happy to see you here and the other TAs as well. Love you too. Y'all helped us a lot last year for the master students. We appreciate you.
Glad it was a mutual relationship, honestly.
Hi, my name is Nadav, and as all the TAs also are, we're second years.
Thanks, Kylie. Struggle City today. I'm Brian. I'm one of your other head TAs. And as you can see, I'm not the greatest at technology. But that's why I got Kylie and Aaron. They're my backups. So they pick me up when I'm struggling.
Alrighty. So obviously this week you guys kind of went over introduction to embryology. You guys had 2 lectures on embryology this week. So how we're going to structure office hours is basically going to be going over some high yield content. And then because you guys do have the exam on Monday, we're going to do some practice questions on embryology. Okay. And if you guys have any questions, what?
I love embryo. It's the best.
Said no one ever. Alrighty. So here are all your contact informations for all your TAs for this module. So if you guys have any questions, you can contact any of us on this list and you'll have our emails when we send this out. Like I said, we can use the clicker. High yield content, practice questions, and then if you guys have any questions about other content, then we can go over that at the end if we have extra time. All right. This is for us. So the first kind of thing we wanted to highlight was knowing gestational age versus fetal age. So when we're kind of like measuring where the embryo is in terms of development, we use gestational age always, which is 2 weeks before ovulation. So it's the day of the last menstrual period for the woman. So just knowing the difference, because sometimes there'll be questions where they give you the fetal age and they'll say fetal age, and you have to remember that that's 2 weeks shorter than gestational age, and gestational age is what you use to measure the point of development. Okay, so just keeping that in mind. Next, a lot of things that I felt like we were tested on that I wanted to highlight were week markers, because they could give you a question that would be like, oh, this mother comes in for her 6-week appointment. She's 6 weeks gestation. What has already taken place? So all of these answer options could be there, and you have to know which one of those is already completed at 6 weeks. So the early ones, they don't test so much. Like the days, that's kind of more just good to know developmentally, especially for when we get to the heterogens, however you say that word. That's more important for the days, but gastrulation being week 3, neurulation being done by week 4, heart development being week 4, those are all really huge ones that I would, it's just straight memorization, unfortunately, for a lot of embryo. Does anyone have any questions about those so far? I'm trying to get through these so we have more time for questions. Oh, nice. So teratogens are your environmental I think it's any substance that can cause damage to an unborn embryo or fetus. So we have any environmental chemicals like heavy metals, carbon monoxide, pesticides, basically anything that could kill mom, could kill the baby. Some medications like isotretinoin, which we all know is Accutane. if any of you guys have been on Accutane, I know you have to like sign that you will take 2 forms of birth control, and it's pretty hardcore because it does like 100% lead to fetal
malformation.
Fetal retinoid
Thank you.
syndrome.
Yeah.
Oh, thank you guys. Blanking on words. Thalidomide was previously used for morning sickness, so that's one that they like to test a lot because some people still use it. It's like old wives' tales. I don't know where people are still getting it, but yeah, that's the one that can also cause like, you guys didn't learn the melias yet, but when you do, some babies can be born without arms, and that could be from the thalidomide. Substances like nicotine, we all know alcohol. I would know like the typical presentation for fetal alcohol syndrome. I wouldn't say you have to know the medication so in depth. I would just kind of know like the name of them. Yeah. But anyways, so alcohol, like fetal alcohol syndrome is like low set ears, flat bridge nose. That'll just come up over and over again. So, just knowing the buzzwords really for the presentation of fetal alcohol syndrome and anything like that. Not really so much infections, but I just threw it on there. Next, Brian, you got it.
All right. So here I just kind of found this image on Google, and it was just the different parts of the placenta just to get you familiar with what the heck they talk about when they say all these crazy words that you've never heard of before, you know, yolk sac, chorion, amnion. So this kind of highlights where all of that is. Biggest thing to note here is you could see where the allantois is, it's number 4, and we'll talk more about what that is later on. You could see the chorionic villi, which will be my next slide, and that's a big high yield point. They love talking about the chorionic villi. And essentially, Kylie, if you want to go to the next page, next slide, sorry. So yeah, with the villi, the chorionic villi essentially are these like finger-like projections that the fetal cells, I guess, they extend out. And what they want to do is that's how they get their oxygen and nutrients from the mother. So the biggest high yield thing that they'll test you on is they'll tell you, you know, it's the end of the 3rd week. The histologist or the pathologist took a slide of the chorionic villi, and they saw fetal capillaries. And you know that would be the tertiary villus, because that's where the fetal capillaries show up. So that's kind of like the extent that you need to know it. I don't think you need to know a lot more past that. If you know that primary is week 2, the secondary villus starts like late 2nd week, early 3rd week, and that's where the extra embryonic mesoderm kind of like folds in into the villi, and then the tertiary week, by the end of the tertiary villus, by the end of the 3rd week, that's when all of a sudden you see the fetal capillaries kind of sprinkle in there. So the high yield point with that is if they ask you at what week will we see fetal capillaries, you know it's the end of the 3rd week. But that's pretty much the extent of the chorionic villi. Does anyone have any questions on that? No? Okay, cool. So next slide here. This one's a really, really high yield one. Yeah, perfect. Implantation location. So where we want, you know, the embryo to implant on the zygote and everything, we want it to implant on the fundus or the body of the uterus. Fundus and body, same thing, just different words because anatomy likes to make things complicated. So whether they say fundus or body, they mean the same thing. So that's a normal fertilization implantation. Day 7, we have the implantation occurs on the body or fundus of the uterus. Anywhere outside of that, it's an ectopic pregnancy. The most common, and I really like this photo that I found also on Google, the most common place for an ectopic pregnancy to occur is in that tube, so it's the ampulla. So if that's a question for you, like the patient has an ectopic pregnancy, where do we expect it to be? you would most likely find it in the ampulla of the uterus. Now, does that mean that it doesn't happen anywhere else? That's not true. There's also those other sections of the uterus that an ectopic pregnancy could happen. Rather uncommon, there is an abdominal pregnancy that could happen where the zygote actually moves towards the ovaries, gets expelled into the abdomen. And honestly, you can still have that baby in your abdomen, and all of a sudden the patient shows up, oh my God, like I have a lot of abdominal pain, what's going on? The baby could actually become calcified. There's calcifications that the body kind of surrounds it in, and it's known as a stone baby. Once again, not so common, but it is something that happens. Will you be tested on that? Probably not. The question on the exam will most likely be leading to most common area that the ectopic pregnancy can occur, or where do we want that implantation to occur? So we answered those questions. Any questions on this here?
I have a question.
What's up?
So the fundus of the uterus is like the top rounded part, right? What's like the difference between that and the isthmic? Is that like higher than the fundus, or?
So the fundus is kind of like the back wall, right, of the uterus. The isthmus is like the very top edge. So it's honestly a matter of just like tiny little differences in location. But so they won't really test you on like that's more of a repro kind of thing to understand where that changes. For the purposes of embryology, as long as you can recognize that the fundus is where we want the implantation, you should be totally good. Once we go into the repro section in the spring, that's where you'll be able to see like it's a matter of like what's it called, like centimeter, like it's not that far apart, but the isthmus is kind of like on the outer edge. It's like the kind of the top part of the uterus, whereas the body or the fundus of the uterus is a kind of more in like the posterior area.
Okay, all right, thank you.
Also, just to add, anatomists will classify the isthmus as part of the fallopian tube, not even part of the uterus. So
yes. Thank you, Kyle. Yes. But once again, that's more of a repro thing. So you don't really have to worry about recognizing it on a uterus. As long as you know, like as long as you recognize those words, you guys should be good.
Do we know where each of these locations are as well? And should we know the symptoms regarding what we should expect if they had an ectopic pregnancy in these different locations? They could, I mean, not necessarily. They might list out some symptoms that they have, but they won't really tell you, like, based off of these symptoms, where is the ectopic pregnancy found. Keep in mind, like, they know that you guys are first years and that this is more to understand what the normal is. So the normal is that the implantation occurs in the fundus or body, and that the most common ectopic is ampulla. But they won't really test you like, oh, patient shows up with these symptoms, where's her ectopic pregnancy? You know, like that's a little too much for you guys as of this point right now. Okay, gotcha. Thank you.
Yeah. So the next slide here, we have placenta issues. So this is a pretty cool photo I found about placenta previa. Essentially, this is where the placenta implants a little too low on the uterus. So it pretty much can either cover part or full, like partly or fully the internal os of the cervix. Into the cervix. The opening of the uterus into the cervix is what they call the os. Once again, that's something that you'll learn more in repro. So this is just to just did it there, Mike. But this is just as a heads up.
All this shit is me.
Hey, can you guys mute? Just
Wait.
Giselle, I think it is.
Oh, sorry.
No, you're good. All right, perfect. So yeah, placenta previa. So normally, as you can see in that photo, to the left, all the way on the left, that's a normal placenta. So that's what you want it to look. You see how the placenta is kind of like on the outer side. It's away from that internal os. And then placenta previa would be one of those three. You have marginal, partial, or total.
And then once again, this is pretty dangerous, right? If this happens, you will have to do a C-section. And typically the high yield hint that you know it's placenta previa is they'll tell you. So in this situation, they'll give you the symptoms that a patient shows up later stages in pregnancy. She denies any pain, but she sees bright red blood coming out of her vagina. And that right there, you have the kind of like the spark, the idea that, okay, this is placenta previa. All right. But once again, I don't think you need to much past that. They could show you a picture. I don't remember personally them showing us a photo of placenta previa and having to know the difference between marginal, partial, or total. Just know that it's a thing, but typically they'll probably just test you on, if they test you on placenta previa, it'll be about mostly total. And like, okay, patient comes in and, you know, there's different multiple choice questions. Well, the answers will probably be placenta previa, accreta, percreta, which we'll talk about next. So you just want to make sure you don't confuse those because they all kind of have very similar names there. But yeah, they won't really, I don't know if they'll show a picture. Kylie, do you remember them showing pictures of this? No, right? Yeah.
I don't think so, no.
Okay, yeah. So the next slide, this is where we'll talk about accreta. So this one's a lot more dangerous than previa. So the accreta, the placenta accreta is where that placenta starts to actually invade into the uterine lining. So as you could see there, placenta accreta, that's the first one. That only goes into the endometrium. Right? Endometrium. Then placenta increta, a little bit worse than that. That invades both the endometrium and mesometrium. And then percreta is the worst one. So that invades all three layers. Basically, all layers are affected with percreta. And once again, this is very, very dangerous for the mother. So this will probably also be an immediate C-section. And probably with this, they'll also do a hysterectomy. So it's a pretty scary thing here. But they will ask a question, most likely about, you know, a pathologist or a histologist takes a sample and they see that it's invaded 2 out of the 3 layers or all of the layers. Know which one is which. Is it the syncytial trophoblast invading the layers? That's a good question.
Like for all of them, for accreta, increta, precita, is it the syncytial trophoblast or is this like different? I know you talked about the mom's layers. I was just a little confused because I saw him talk about that in his high yield slide. High yield notes.
Yeah, that's a good question. Kylie, do you know if it's a syncytial trophoblast? I want to say that those are the ones that do invade, right? Like those are the ones that are the going into the, yeah, perfect. So yeah, you guys know more than me. It's easy. But yeah, the syncytial trophoblasts are the ones doing this. So we don't want them to go all the way in to the mother's lining. Yeah, good work, guys. What do you guys need TAs for? You're good. You're good. Any other questions about placenta issues, whether it's previa, accreta, increta, percreta?
The syncytial trophoblast, those are also responsible for like the ectopic pregnancies, because right? Or is that something different?
So the syncytial trophoblasts, they are not, because the ectopic pregnancies, and let me go back to that slide, that's actually the zygote, right? So that's once, you know, the sperm hits the corona radiata and it gets caught by the and this is honestly, this is very repro. I don't know how much, because I know Dr. Vidal is relatively new to Middletown. But typically, once it gets into the fimbrate, then it goes through the fallopian tube, which the ampulla is a part of, isthmus, and then it goes to the body of the uterus. So it's not really, the syncytial trophoblast portion is once it's been implanted, that's when those cells start acting. It doesn't really have to do with ectopic pregnancies.
Okay, thank you.
Yeah. I hope that made sense.
Just a quick question. Would they also ask you about symptoms for like placenta accreta, increta, or percreta? Would you be expected to know what symptoms are associated with which ones?
They might put that in the stem, but okay. they will it's like hard to explain because typically the way these questions work is they'll include it in the stem, but then at the very last sentence, they'll say, oh, we noticed that it invaded two layers, you know, so it'll be like your buzzword type of thing. So my biggest recommendation, especially with taking anatomy exams, go slow on the question, right? Don't rush through it, because when you rush through it, it can be like, oh, they're asking about this, but they're not. They're asking about something else. So make sure you read everything thoroughly. But when it comes to embryo, they don't want to trick you because embryo in and of itself is tricky, you know? So they'll try to be as straightforward with it as possible, without making it obviously like too easy. They won't try to trick you with it. So with the placenta accreta questions, they will most likely tell you if it's invaded 1 layer, 2 layers, or all 3. And it'll tell you like, oh, patient had to be sent in for an emergency C-section and hysterectomy. Like they could tell you all of that. But they'll definitely mention the layers part.
Thank you.
Yeah, of course.
Alrighty. So now I just kind of wanted to cover quickly types of twins and kind of what they share. So I don't remember if it was like a exam question or if it was just a practice question. But they could ask like, oh, like a monozygotic twin separated at day 5. What would you expect to see? Like, would they share 2 amnions, 2 chorions? So just being able to kind of memorize, unfortunately, the stages for monozygotic twins. So basically, the earlier they separate, the better. The later they separate, so when we get closer to 2 weeks of pregnancy, that's when we start to have conjoined twins, and we start to get a little concerned with what's going on. Yeah, so that's just straight memorization. If you guys have any questions, that's not really high yield, but it's just something because I feel like a lot of people brush over it and it could be an easy question. So just wanted to mention it really quick.
So this one's also relatively high yield, the diaphragm formation. So the septum transversum is brought in by the craniocaudal folding, where it goes from a trilaminar, goes like this. It's so hard to kind of show it. So I've linked a couple of YouTube videos that I really like that actually show how the whole embryological thing occurs, how it folds. But as typically what happens is that septum transversum will give rise to the central tendon of the diaphragm. The pleuroperitoneal folds grow from the dorsal aspect of the pleuroperitoneal canals, and that dorsal mesentery of the esophagus serves as that anchoring point for the pleuroperitoneal folds. And then after that, of course, the migrating myoblasts from C3, C4, C5, they complete that diaphragm. Hence why the innervation for the diaphragm is C3, C4, C5. With that mnemonic, it keeps the diaphragm alive. So the biggest clinical correlate with this is that if you have a baby with a diaphragmatic hernia, so for some reason he's agitated, something's going on, all of a sudden they do an imaging of him, and his intestines, if you can look at that image, are outside of that left-sided part of the diaphragm there, and that means that left pleuroperitoneal membrane lagged and did not fuse. So therefore their intestines actually will go up, and it's not great. So this is something that's high yield, especially just knowing like the septum transversum gives rise to the central tendon of the diaphragm. The dorsal mesentery of the esophagus serves as the anchoring point for the pleuroperitoneal folds. I don't know if you really need to know about the innervations just yet, but just kind of know these, like, it's honestly just word associations with when it comes to embryo. And then the next slide here, this is kind of like my high yields that I kind of remember over the years. So syncytial trophoblasts are the cells that release that HCG. So whenever you do a pregnancy test, the reason you can tell that you're pregnant is because of these cells. These cells tell them that you're releasing that human chorionic gonadotropin. So that's pretty high yield. They'll actually ask you straight up. That'll be like a first order question. Person takes a pregnancy test. what are the cells that releases the, the marker, and it'll be your syncytial trophoblasts. In addition to that, the cranial caudal folding is driven by the growth of the neural tube. I think this was a question last year. And that the notochord provides the signals for the formation of the neural tube, but it does not drive the specific folding. I think I got this one wrong because I thought it was the notochord, but it's the neural tube. So keep that in mind.
You're better than me. I thought they were the same thing for the longest time.
So yeah, just keep that in mind. And then what I did here, I mean, I overload you guys with these resources, but these are just a lot of I'm a very visual person. And when, I don't know if Professor Rosenthal really does the embryo stuff anymore, but like she used to have like a tube and and I just couldn't picture what they were talking about. These videos really help me out because they actually show you the movement of everything, and how the embryo goes from being, flat to all of a sudden it's 3D and everything like that. So I definitely recommend checking these YouTube videos out, and they're not long. It's not like a Ninja Nerd 48-minute video. They're all like 5 to 10 minutes max. So just check them out and kind of visualize how it all happens, and that'll help you understand why things are happening and why things are called like foregut, midgut, hindgut type of thing. Embryo sucks, but you guys will do it. You'll get through.
Alrighty, so now we have some practice questions. They're all embryology related practice questions. So I'm kind of thinking like 2 minutes per question? Maybe 1:30. I know that's pretty fast, but we only have 25 minutes left. So just try your best. They will be posted if you can't keep up with it. And please feel free to ask any questions. So we'll get started. I don't know which TA wrote which question, but if you guys want to go through and read it when it's your question, like I'll click through and then I'll start a timer for 1:30.
Okay, so this was one of my questions. The question is, which developmental process normally occurs during week 3? And it's either body folding, organogenesis, gastrulation, or facial and limb development.
Okay, so 1:30 is going to be way too long. So seeing a lot of answers for C, which is great because it's C.
Can we go over why each one of them is wrong just to keep the muscle memory going?
Yeah, of course. Jenna, you want to?
Yeah, so I think pretty much just from the slides above, all these other ones happen a little later. Like this step, the gastration, is important and it has to happen for all of these other steps to go. Unfortunately, my best advice for these is kind of just like memorizing the actual weeks, but my best suggestion that helped me is kind of like laying it all out in a timeline so you could kind of see what was happening, and then unfortunately like memorizing the actual like segments that each thing happened. But it really helped me to just like lay it all out on a timeline to like see what was happening as we were going through, and then memorizing the weeks and the segments from there.
Does anyone have any other questions about that one? Yeah, perfect. So I, like Jenna said, it kind of helps to think about it like as like a timeline of everything. So the way I kind of think about it, gastrulation means to make the little pocket in the embryo. So if there's no room to grow, the embryo will not grow. So first I got to make that pocket. Second, I got to fold because, we're not 1D, we are 3D humans. So we have to fold now. Then I have to make organs, and then I have to make limbs and everything. So if you kind of think of it like stepwise building a human, that's kind of a way, instead of just memorizing like gastrulation, like what does it mean? Alrighty.
Oh, this is also mine. What is the most common location of an ectopic pregnancy? The ampulla, the cervix, the uterine fundus, or the abdominal cavity?
Oh yeah, that's what I'm talking about. Yeah, yeah, good grades. Yeah.
Even Nikhil learned something. He's answering in here. All right, guys. So does the ampulla. All right. Any questions about that one? All right, perfect.
This one's mine. A researcher studies an embryo that is known to be 7 weeks post-fertilization. The pregnancy would most likely be described as having a gestational age of what? Yeah, so it's D. You just add 2 weeks. That's it. They might have a little bit of a weirder situation where they give you like a different number. Just know that post-fertilization and gestational are 2 weeks apart. That's it.
And when you do your questions on the exam, read very carefully because they could give you
Yes.
the fetal age or they give you the gestational age. So
Yes.
if you do it too quick, you'll miss it. So read very carefully.
Make sure you know when to add 2 weeks or subtract 2 weeks. I got this question wrong last year.
And fetal age is the actual age and corresponds with the shown diagrams that we see in our books and slides, correct?
That's going to be gestational age. So gestational age is more accurate when it comes to determining what part of development the baby's in. So when we use fetal age, it's actually like a fetal full-term pregnancy is only 38 weeks, where a gestational pregnancy is 40 weeks. So in medicine, we'll always use gestational age.
Sorry, this is my question again. So a pregnant patient presents with bright red vaginal bleeding and denies any pain. Which placental abnormality does this match? Read that.
You guys are killing this. Easy peasy. Yeah, it's C. Does anybody want to take a shot at what the other three are? Or one of them? Okay, Sayad.
Yeah. Accreta is when the syncytial trophoblasts invade the endothelium and part of the mesothelium. Increta is when it goes it invades the endothelium, mesothelium, part of the parametrium. And then percreta is when it invades all three layers, and it's the worst.
Perfectly said. Yeah, so the other three could cause bleeding, but they would be extremely painful.
Yes, it's heavy bleeding, and it's very, very dangerous. And it's unexplained. I don't want to say that it's darker because it's weird to like really say that, but like the blood won't be as bright red as it would be in Previa. So the blood's a little more severe. And yeah, so that'd be a good one. I like that. But you still are definitely bleeding in Accreta, Percreta, and Increta. It's just a lot more life-threatening than Previa.
In terms of how close these are to actual exam questions, a lot of these questions are first order. here today. But say for like the gestational weight age one that Nikhil had done earlier, if you merge that with the what stage or what has already been done in development, that would kind of be, so like you could be given a fetal age, you have to figure out gestational age to figure out if gastrulation's already been done. So it's kind of like those would be third order. These are more first order.
And for embryo, once again, they're not trying to trick you. So don't think that the questions are going to be just symptoms and figure it out. Like, they're going to tell you what they're looking for. It's just a matter of, do you know it or do you not? That's why embryo is very difficult, because it's kind of like rote memorization. But like, it'll be pretty straightforward when it comes to embryo. You won't think it's straightforward, but when you start figuring it out a little more, you're like, okay, that was pretty straightforward.
This is my question. Which class of antibiotics can cause tooth discoloration? A, tetracyclines, B, beta-lactams, C, cephalosporins, D, macrolides, E, aminoglycans.
This topic doesn't leave. Know it now, know it forever. Great question.
Yeah, this was kind of a little side bit in your little embryo slides, but I think it's going to come up in every single class. So might as well get her down now. Alrighty. So this is A, like most of you guys were able to figure it out. You'll learn more which ones specifically in your tetracyclines are worse for children, but just good tidbit to know.
All right, again, this is my question. The parents of a 3-month-old male present with concerns regarding his delayed developmental milestones. On physical examination, patient has a flat nasal bridge, thin upper lip, and a smooth philtrum. Further inspection reveals growth deficiencies as the child is below healthy weight. When talking with the parent's mother, she admitted to taking a substance during her first trimester. What syndrome does the patient have? All right, people look like they're doing good.
Alrighty, looks like a lot of you guys figured it out. Fetal alcohol syndrome.
A philtrum is like that thing between under your nose to the bow of your lip.
Also, somebody asked about isotretinoin and the Accutane. That leads to really severe fetal defects like microcephaly, VSDs, like complete degeneration of any internal organs. So that wouldn't be so much like a facial appearance as much it would be like the baby's born stillborn.
What is the critical period for heart development? A, weeks 6 to 8, B, weeks 3 to 6, C, weeks 9 to 14, D, weeks 1 to 4, E, weeks 1 to 3, 1 to 2. Right? People are doing good.
Alrighty, looks like a lot of you guys were able to figure this one out. It's also B.
I think this one was mine. Woman undergoes chemotherapy, which slows the rate of mitosis in exposed cells. Unbeknownst to her, she's also pregnant. This cancer treatment may have a negative influence on the implantation and growth of an embryo. In which of the following layers would a decreased rate of cell division be most likely to hinder implantation of the blastocyst? Okay, so I see everyone is between C and D. Sorry, D and E. Which is actually why this question is a little confusing. This was a question from I think 2 years ago. We saw something very, very similar to this. The actual definitions of what these cells are is like kind of important. Like it's really just memorization, as Brian and Kylie keep saying. It's like it's a whole other language, and you just kind of like need to learn what these words mean. So cytotrophoblasts are the stem cells for syncytiotrophoblasts. And I know earlier before, someone was asking like, oh, like is the syncytiotrophoblasts the part that like invades the uterus and stuff? Kind of. It's really like which, that's the cells that actually like the outer area. As you can see in this diagram, it's like the outer cell layer. But the cytotrophoblasts are the stem cells. So when you undergo chemo, it's the cell layer it's the basal cell layer, which are the stem cells. That's the cell layer that would be most affected in this case. Another point, which I don't think I wrote on here, which confused like the hell out of me when we were learning this originally. So you have the primary villi, secondary, and tertiary. In the lectures, it kind of states like, the primary villi is the beginning of week 2, and then the tertiary villi is like the end of week 3. The villi grow asynchronously. So it's not all of the villi growing all at the same time. So like it's not like the beginning of week 2, all of them are primary villi. And then at the end of week 3, they're all tertiary. It's beginning of week 2, you'll see the first primary villi, and then at the end of week 3, you'll see the first of the tertiary villi. And throughout the rest of the pregnancy, you're going to have like, I guess, like new growths of these different villi of the placenta. So hope that clarifies. I don't know. Hopefully you don't have that question, but if you do, now you know what to answer.
Yeah, you can get it wrong today as long as you get it right on the exam. That's all that matters.
Exactly.
This one's mine. A single fertilized ovum divides approximately 5 days after fertilization. Which placental configuration is most likely?
Yeah, you guys did great. Looks like almost all of you guys got that. And yes, it is the blastocyst stage. If you wanted to go more over it Caleb?
Yeah. So, I mean, this isn't great to just memorize. I think you should. There's a really good diagram on one of the slides I remember last year that went through like why each of these happens. But just if you can think of it in each stage, like from 0 to 3 days, it divides, and then you have two separate, similar dichorionic, diamniotic. If that makes sense. Sorry, I would highly recommend going and looking at that the diagram they have. But so 5 days, you have a monochorionic, diamniotic embryo, placenta. That's you can. I would highly recommend looking at that. There were like 2 questions on this last year, and I got both of them because it explained it really well, better than I can here. Sorry, I probably should have put it on this slide. Actually, I can still do that. I'll put it on while I'm sitting here.
I do believe this is our last question, so we'll keep roasting you.
This one's also mine. A researcher observes a developing morula in which a small fluid-filled space has begun to appear. Which developmental time is most consistent with this finding? Yeah, so it's B. The cavitation of the morula, which is what the small fluid-filled space appearing, that's what this is describing, happens day 4 to 5 of development. So day 7 to 8, blastocyst, the whole thing adheres to the wall, and then week 3 is the gastrulation, and week 4 is heart development. But this one also just kind of memorized. Again, it's embryo. No one really likes it. You just have to memorize what's going on at each point. Good job.
Sorry, I'm a liar.
Kylie, you lied.
Yeah, I was like, I feel like I put in another one. Yeah. Which sequence best describes the structures that characterize the progression from primary, secondary, and tertiary chorionic villi? Yeah. So good job. The cytotrophoblast, you have the 3 stages of the chorionic villi. This was pretty similar to the question that was on there last year. Just no cytotrophoblast defines the primary stage. Extraembryonic mesoderm is secondary. Fetal capillaries are tertiary. And I feel like they might ask something similar to this.
They typically do, 100%. They love the chorionic.
Yeah. So.
Yep. But good job, guys. You guys are good. So before, this is crazy.
So I found out that Jenna is the one that used AI to put both of our white coat pictures together.
It looks so real. It's nuts.
It's
Yeah,
really
that's a real
creepy.
photo they took on White Coat Day.
No, I was wearing pink. That's the funniest. But like, it changed my whole outfit.
But I did want to, before we let you guys go and have you guys ask us questions, I was speaking with one of the professors this morning, and so kind of like off the record stuff here. I've been told that if you guys focus on Dr. Vidal